Thank you, everybody, for being here, and thank you for Sean and Leah and everybody else for inviting me. It's been such a pleasure to be at this meeting for several years now. So my task is to talk about epilepsy syndromes in the SCN2A spectrum, a little bit about the ABCs of the words you might hear from your doctors. Disclosures, I am on the medical advisory board for the foundation. I collaborate with Dr. George and Dr. Cummins on some functional analyses of our patient variants. We had a T32 grant for one of my fellows. She started some work on SCN2 related disorders, and I just finished K23. So our objectives, we're going to talk a little bit about a couple words just to know about locus heterogeneity and variable expressivity. They're not critical for you necessarily, but just to understand the context of how genes and syndromes interact. And then we'll talk about the syndromes. So this is just a little bit of background. What do we mean about locus heterogeneity? So what this means is that there are a lot of different causes of epilepsy, some genetic and some non-genetic, but in the last 10 plus years, we've really exploded in our understanding of the genetics in epilepsy. Even this slide is a little undersimplification, but there are hundreds of genes that cause epilepsy. And epilepsy syndrome is literally just a combination of what are the seizure types, when did they start, what does the EEG or the electrical pattern in the brain look like? And you put that together to come up with a syndrome. There are also some syndromes that are starting to be gene-based. So we're getting there with SCN2A as well. But multiple different genes can cause the same syndrome. So you see SCN2A in a couple of places on this slide, for example. And then there's a term called variable expressivity, and this is a little bit outdated as far as the terms. So the other thing about epilepsy syndromes, which gets really confusing, is the International League Against Epilepsy defines these syndromes, and every 5 or so years, they change the names. So it gets really confusing. So even these terms are old already. But what it shows you is with a variant in SCN2A, it can present in multiple different ways. And in any given individual in your family, you may hear different terms over time because some of these syndromes are age-based and you evolve from one to another. So this is a little bit of data from a study called Gene Steps, which Boston Children's Hospital, where I'm from, I'm part of our epilepsy genetics program, is part of, and it's an international study with 3 sites. And what it's doing is rapid genome sequencing for infants with new onset epilepsy. So within 7 days, we have genome sequencing, which does a spell check as well as looking for structural variants like deletions, duplications, or other complex structural changes. And so this is some of the early data that my team, I was part of this, but not leading this in any way, put together. And you'll see that SCN2A is one of the genes that pops up here in a few different areas. So in the first week of life, at 2 months, at 4 months, it has different presentations, but it's coming up amongst other genes. And we're diagnosing patients earlier through this study. And I hope that that expands across the US and internationally, as there are now guidelines for diagnostic genetic testing in epilepsy that's unexplained. So I showed this slide yesterday. It's imperfect and broad strokes, but a little bit of a kind of big picture breakdown of where the epilepsy falls in the SCN2A spectrum. So there's the self-limited epilepsies, and what that means is that it usually presents in the first 2 years, often in the first few months with seizures, but the baby is otherwise looks well. Development usually progresses normally, though you can see some milder cognitive and developmental impacts, and you can see seizures later in life in some individuals, but for the most part, there's a relatively positive outcome. And that tends to happen with milder gain of function variants for the most part. Again, the electrophysiology is very complex, as you heard if you were here at the beginning of the day yesterday. So this is not an exact science, but in broad strokes. And then there are the developmental and epileptic encephalopathies, a term that means that the underlying problem, the SCN2A variant, and the seizures and the EEG patterns are both contributing towards the abnormal developmental course. And then you can have epilepsy outside of that, and you can have intellectual disability with no epilepsy. But today we're focusing on, in this session, we're focusing on the epilepsy. And there are also movement disorders. The episodic ataxia can overlap. It's not necessarily independent of these other groups. It can happen within them, especially with gain of function. So this self-limited epilepsies can run in families because the outcome is generally positive. So on the top right there is a picture of a pedigree, if anybody's ever seen one, where girls and females are differentiated, and then the black dots are the affected individuals. So the arrow is pointing towards the proband of the person being studied, and the rest are their family members. And you can see in this family, there are multiple affected family members with a variant in SCN2A. So the seizure onset is anywhere from 2 days to 23 months. Seizures are often focal with stiffening or shaking, with or without apnea, where you stop breathing. Most are fairly easily controlled with anti-seizure medications, as I mentioned yesterday, particularly sodium channel blockers for 2A, but really even non-sodium channel blockers may control those seizures. And the seizures usually resolve early in life, and individuals can come off of medications with encouraging developmental and cognitive outcomes. You can see episodic ataxia, which is a movement disorder of balance in a subset originating from the cerebellum. I don't expect you to read all the fine print here. This is essentially showing you similarly those self-limited epilepsies that I mentioned. And it's really not two separate boxes, but more of a spectrum between that and the developmental and epileptic encephalopathies. There is a middle ground there of having some developmental challenges in epilepsy, but not necessarily to the same severity. And 2A as well as KCNQ2 are the most common causes, at least of those presenting in that super early infantile period. I left the etiology-specific ones down there, even though SCN2A isn't on the list, because I think it needs to be eventually, so we should advocate for that. So just an example of maybe a self-limited epilepsy, a boy who was born a little bit premature at 34 weeks, no perinatal complications, had onset of focal modal seizures, which just by focal, I mean they start in one part of the brain rather than a deep focus that looks like it's coming from everywhere at once. And secondary generalization or evolving to bilateral stiffening and shaking at 3 months. He had normal development and cognitive outcomes through kindergarten. He had episodes of possible focal seizures that happened later in life, though, feeling shakiness or slurred speech, shuffling gait. Those hadn't fully been characterized, except that he'd had a normal 24-hour EEG at 6 years, and so it's a little to be determined. Next syndrome we're going to talk about is the early, one of the newer terms for the ILE is early infantile developmental and epileptic encephalopathy. Some of the older terms that fall into this bucket are Ohtahara syndrome, myoclonic epilepsy of infancy, and there are others that don't have that EEG severe background called burst suppression. The onset by definition is less than 3 months for SCN2A. Many of these are in the first 2 weeks of life, as you heard yesterday, even the first 2 days of life. Epilepsy is often refractory, often associated with, or typically associated with global developmental delays and intellectual disability. The most severe EEG pattern that we see with that is something called burst suppression that I'm going to show you in a minute, but there can be a spectrum of other electrical patterns. And other features that we often see include movement disorders. You've heard about some of these here as well. Dystonia is one of the most common ones. Also choreoathetosis, which is more of a wiggling type movement disorder. Dyskinesia is non-purposeful movements. You see abnormal muscle tone that can be low or high or low centrally and high in the extremities. Cortical visual impairment or cerebral visual impairment, which we just heard about, is very common in this group and not always recognized by neurologists, so important to bring up. And then autonomic symptoms we had a talk on yesterday are very common as well. So a subset of that group is the early infantile DEEs with burst suppression, and these are amongst the more severe epilepsy syndromes in infancy. Common seizure types include epileptic spasms, so you crunch for just a second or two and then relax, but they come in clusters. And you'll hear more about seizure types in the next talk, so I won't go into too much detail. Tonic seizures are stiffening, myoclonic are kind of lightning fast jerks. I'll show you the EEG set in a second. And SCN2A is just one of multiple genes that can cause this syndrome. Sodium channel blockers usually work the best in this group with early onset because they tend to be gain of function, but they may not be adequate. And as I mentioned in the question and answer session yesterday, we often need very high levels of phenytoin in particular, where you're teetering on toxicity. So that's what burst suppression looks like. Each of those letter number combinations is one of the electrodes on the scalp if your child has had an EEG or family member. And And each of the lines there is two of those electrodes, the difference between the two electrically. What you see with burst suppression is high amplitude bursts of very irregular, sharp-looking activity, followed by periods of suppression where it's quiet, and it just looks like that throughout. There's no variation. So I mentioned that these syndromes are something that can change. So on the far left side of the screen there are the early infantile developmental and epileptic encephalopathies. That's what we just talked about. Those present in the first 3 months of life, but you don't necessarily maintain that pattern over time. The burst suppression tends to go away and evolve to other patterns. So on the bottom screen EEG are different EEG patterns that we might see. So you might evolve into something called hypsarrhythmia, which doesn't have those periods of suppression, but it's also high amplitude and chaotic, and could go along with a seizure syndrome called infantile epileptic spasm syndrome. So your individuals can evolve from one of these syndromes to another, and there's some percentages there as to how many patients tend to evolve on to the next syndrome. So it's the way your brain is responding to the electrical and the chemical abnormalities more so than the specific underlying cause. This isn't specific to SCN2A. It's across genetic causes of epilepsy and the ages that they present. But it does happen in SCN2A individuals. And Lennox-Gastaut syndrome is another syndrome that can present in and of itself at a later age. And the recent study from the Clinical Trial Readiness Project, this is the syndrome that was most highlighted. I think it's about a quarter of patients across the age groups that end up with Lennox-Gastaut syndrome. It involves multiple seizure types and some specific EEG patterns as well. So also, I don't know if she's still in the room. There she is. Our child neurology resident, along with our fellow Isa Haviland, who is actually here as an intern at CHLA now. Couldn't be here today because she's working. Put together a series of our SCN2A cohort at Boston Children's Hospital who we've seen clinically. And this is a little project where we highlighted a couple of individuals, and there are similar individuals in the literature who had variants in the specific cluster from amino acid position 430 to 434, who had that severe early infantile developmental and epileptic encephalopathy. Seizures were very hard to control in the first few months, but then they just sort of resolved. And they stayed away, except for one of those two individuals had seizures later that have been controlled on a single medication, lacosamide, which is a sodium channel blocker, but fairly easily to control. They still have a significant, both of them, developmental disorder. It's not that it all went away by any means, but the seizures seem to go away, which is very different than many of the kiddos that we see in that presentation with early onset severe seizures, where they go on to those other epilepsy syndromes and they continue to be very challenging to control over time. So one question is, what is the difference? Is there something different about this little cluster or region of the protein? Is it, in Ted Cummins' functional studies, it looked like they didn't have an impact on the persistent current, which is kind of like a leaky valve after the initial sodium channel burst. There's the initial activation, and then there's the persistent current. And these didn't seem to have impact on that. So is that a factor? We don't know yet, but there are some similar patients in the literature, and it looks like it's potentially a pattern. And there may be others. We need more genotype-phenotype correlations so that we can help families predict better and also target who's going to be best candidates for different treatment approaches as we have precision therapies coming. So another early infantile DE is called epilepsy of infancy with migrating focal seizures. Age of onset for the syndrome overall is less than 6 months. In 2A, it's usually less than 8 weeks. These are focal seizures that if you watch on the EEG, they start in one hemisphere, one side of the brain, and then while they're still going, they sort of migrate around to different portions of the brain. So it's a funny epilepsy syndrome. And can be very challenging and hard to control and associated with severe developmental delays and cognitive impairment. When a team, including our group, looked at the genetic causes of this particular syndrome, SCN2A is not the largest, but it's amongst the more common causes of this particular syndrome. So here's just another example of early infantile DE, a term baby girl, prenatal complication, no prenatal complications, no problems around the time she was born on that first day of life, but she had seizure onset right on that first day with focal stiffening type seizures, multiple per day, had partial response to multiple sodium channel blockers, and it took a very long time to get any seizure control. But later in kind of mid-childhood now, she has fairly good control in a combination of lacosamide and lamotrigine. Started with verse suppression pattern on the EEG that did evolve to other patterns over time. And she has very severe global developmental delays, intellectual disability, swallowing difficulties, poor weight gain, and actually some motor asymmetry that's not entirely explained. So the infantile and childhood onset DEE is beyond that neonatal subset in those first through months. There are several. Infantile epileptic spasm syndrome, I'll tell you a little bit more about. There's epilepsy with myoclonic atonic seizures, so drop type seizures has been reported. Lennox-Gastaut syndrome I mentioned is very common. And there's another syndrome called epileptic encephalopathy with spike wake activation in sleep. Essentially looks like a consistent spiking pattern in sleep, and that can cause loss of developmental skills. And that has been seen in 2A. So if there's a sudden setback in development, you sort of have your trajectory over time and suddenly skills are lost, it's something to think about getting an EEG and capturing sleep to make sure that it's not being missed. And again, in the subset, we can see other associated symptoms. So infantile epileptic spasm syndrome, just one other example, a baby who had normal birth, normal early development, but then started with their seizures at an older age at 10 months with epileptic spasms, had some control and then recurrence at 3 years. There was developmental regression with almost no interaction at the onset of those epileptic spasms. And then subsequent seizure types have been more focal, starting on one side and evolving to full body stiffening, shaking seizures. And that individual has a severe choreoathetosis movement disorder as well. So this is more one of those intermediate syndromes with a probably mixed impact on the channel. So infantile epileptic spasm syndrome is not specific to SCN2A, as many of these syndromes. There are many of them. In that top left group, you probably can't read all the details there, and that's okay. SCN2A is one of what we call the channelopathies, so the different channels in the cell membrane that help chemicals get from one side to the other and regulate the electrical activity and the release of neurotransmitters that tell the brain to be more active or more quiet. So it's one of many causes. And it is commonly associated with developmental stagnation and regression. There are standard treatment approaches, ACTH, prednisolone, and vigabatrin. We need to study it better in SCN2A. There's a little bit of literature out there to suggest the response is not as good as epileptic spasms overall to these first-line medications, that we may need other things. And I mentioned briefly yesterday, too, that we are starting a trial to look at prevention of spasms with ketogenic diet as well. And then the final subset that I'll talk about are the autism spectrum disorders and intellectual disability with or without epilepsy, but onset beyond a year of age, often in that subgroup. And that's pretty heterogeneous. Many of those individuals don't fall into a syndrome, but if they do have a syndrome, Lennox-Gastaut syndrome is the most common, which consists of multiple seizure types, mostly generalized drop seizures, very common. And there are a lot of drugs that are approved for Lennox-Gastaut syndrome, but you want to think about it in the context of LGS with SCN2A when you're thinking about treatment options. And this is not a syndrome, but just to add, there's a small subset of individuals who have renal malformations with their SCN2A variants. Most individuals are going to have a normal looking MRI, like on the right side of the screen, but we have seen polymicrogyria, which means poly means many, micro means small, and gyria are folds. So there's too many small folds and it looks kind of clumped up is what it ends up looking like. So if that's the picture, it does change sort of what's driving the seizures in addition to the sodium channels acting abnormally. Those changes in the cortex of the brain definitely drive seizures as well. And it just changes a little bit as epilepsy doctors how we think of it. But it doesn't change the syndromes overall. It just changes the context. That's it for now. Any questions?
I can collect any questions, but I'll start while people write them down. So as individuals grow from one syndrome to the next. Just a kind of a coding question. I've noticed Harper hasn't had spasms in a long time, doesn't have hypsarrhythmia anymore, but they still code her as West every time she goes to a clinic visit. Is that appropriate or helpful, or should we be recommending that come off, or how is that typically done?
Yeah, that's a good question. I mean, it's probably listed there because historically she had infantile epileptic spasms syndrome, which we used to call West syndrome. Um, I think it's okay to have it there as long as it's in the context, there's clear context of what seizure type she's having now and that she no longer has hypsarrhythmia.
Sure.
I wouldn't include it as her active syndrome.
Okay, thank you. Any other questions? I'll ask another one. Then, in regards to the syndromes, I think there's a lot of information that goes into kind of clinical decision making within SCN2A, like variant. Um, how much goes into like what syndrome they have and like medical decision making versus other elements that you consider within our children?
Yeah, that's a great question. So it plays in more for some syndromes than others. So for infantile epileptic spasm syndrome, there are three top medications, and those are different from the medications that we use for other seizure types. So there it weighs in very heavily, whereas with some other syndromes, not quite as much. So it's one piece of the puzzle that we put in, and it may give us in that avenue, it gives us actual data towards which medications are going to work best. In other avenues, like the Lennox-Gastaut syndrome, it gives us access to certain medications that are only approved for Lennox-Gastaut syndrome and not for other seizure patterns. But you want to put it in the context of what seizure types they're having, what other medical problems do they have, what other medications are they on, what are the interactions, potential side effects, is your child prone to sedation from medications? So there's a lot of other pieces of information that get pulled in aside from the epilepsy syndrome.
And we have Lyle with a question.
My son is only 7 months old, so we've gotten spasms under control, but we've also been told he has, and we've seen them tonic seizures. He also has chorea and dystonia. Through multiple hospital stays and EEGs, we've been getting confused now at home trying to determine what is a tonic seizure and what is dystonic movement. And we're just trying to, how do we determine what is what when he's going through some of these either movements or a seizure so we can better report and to the doctors what we're seeing and helping him?
Yeah, that can be really challenging sometimes, and a great question. With dystonia, individuals are usually alert to some extent. So if he seems aware and looking around, that's a good clue that it's maybe but full body stiffening. That would be a clue that it's more dystonia than seizure. It may be helpful to go through some of those EEGs and the videos with your clinician to see if you and they can kind of pinpoint some very specific differences for him as to what you're seeing with the two, because they can overlap quite a bit. And if there is uncertainty as to whether he's having seizures or not, sometimes we need more EEG to help us differentiate as well.
Any more questions for Dr. Olson? I got one more then. You mentioned that we should be advocating for an SCN2A syndrome. How do we go about doing that?
That's a great question. You can actually get an IC. I don't know if you guys have looked into ICD-10 codes. That is one way, and advocacy through the ILE, I suppose, International League Against Epilepsy, towards developing a gene-specific syndrome in their next rendition.
Thank you very much.